Okay, Manisha, you can start.
Very good afternoon, everyone. A very warm and heartfelt welcome to all respected faculty members, seniors, embryologists, clinicians, and dear colleagues joining us today. On behalf of Academy of Clinical Embryologists of India, that is ACE, it is my privilege and honor to welcome you to this prime scientific session of our fraternity, a session that truly reflects the evolving landscape of clinical embryology in our country. As we all can see, clinical embryology today is advancing rapidly with growing emphasis on quality, accountability, and global benchmarks. And as a professional community, it is essential that we evolve not only in technology and skills, but also in standards, validation, and structured assessments. ACE has always been committed to ensuring that Indian embryology stands at par with the best in the world. And with this vision, ACE has conceptualized the ACE Accreditation Certification Examination, an initiative aimed at recognizing competence and promoting uniform high-quality embryology practice. Today marks an important milestone in that journey, and to formally introduce the ACE Accreditation Certification Exam and to share the vision behind this initiative, it gives me great pleasure to invite our President of ACE, Dr. Sujata Ramakrishnan ma'am. Ma'am, leadership and dedication have been central to this initiative, and it's my privilege to invite her to brief us about the ACE Accreditation Certification Examination and its vision. Over to you, ma'am.
Thank you very much, Dr. Manisha. Good afternoon, everybody. It actually gives me a deep sense of pride and purpose to be here this afternoon as we are here together to witness two landmark moments in the journey of ACE. We are honored to have Dr. David Gardner talking to us about the future of IVF lab. His work not only educated generations of embryologists, but also shaped how IVF works across the world. Most of us, I'm sure, began our embryology journey with his textbook on our desks. And more on his work and more about Dr. David Gardner will be mentioned by Dr. Rajvi, and a lot of those details will be said later in the session. But equally important and in many ways transformational is the second event. And in fact, that is going to be the first event of this afternoon. It's the launch of ACE Accreditation Program. Given its significance and its long-term impact on our profession and the IVF ecosystem, I felt it was important for me to briefly introduce this initiative. Why should we have accreditation and why now? We all know that IVF outcomes are highly operator sensitive, meaning embryos are created by people and not just by processes. And if these people, if they are, the key to processes where certain decisions in the labs are irreversible, and without accreditation, it is a nightmare. And we all know that there is a rapid expansion of IVF clinics in India, and we really need not just qualified, skilled, but also validated embryologists to run these programs. And in this country, we do not have a uniform national benchmark for embryology competence. In fact, even with the existing qualification system, which is actually prescribed by the National ART Board, we are finding it difficult to accommodate all our workforce. And we, in ACE, we felt that accreditation actually can bridge this critical gap. Can I have the next slide, Aarti, please? Aarti, the next slide, please. So, who all are going to benefit from this accreditation program? First, patients would be benefited because, for them, it directly translates into safety and trust. And when they know that their embryos are being handled by people who have been validated or who have been accredited, that gives them lots of reassurance. Clinics, for them, it's like an objective staff validation. And this will actually prepare them for audits such as NABH audit, and like it will also help them in reducing risks in their programs. They can very confidently say that, like, we have kind of validated embryologists running our program. And for embryologists, it's needless to say, an accreditation would actually give them a unique and formal professional identity, and it will also help them in career progression. And for the IVF industry as such, it would help in consistent outcomes, and we can also align our work with the global expectations of the global standards, which actually will put us in the field of infertility on the global map. Next slide, please, Arti. So why ACE is the right body to do this accreditation? ACE is the right body because I can proudly say this is an embryologist-led professional body. This is created by embryologists, and this is created for embryologists. And since we are all working in the lab, we do have a deep understanding of what exactly happens in the laboratory. ACE represents embryologists across the country, and as of today, we have 1,045 embryologists from metro cities to two-tier cities to three-tier cities, from large chains to single labs, like standalone labs. So hence, we are in a position to help form uniform national standards for embryology skill and work. Next slide, please, Shanti. And because we are also planning not just on the credentials, but on the competence of embryologists, like with emphasis on practical skills. Though we may not start with that, but this is the plan, like how people, like the understanding about SOP adherence, the quality systems in the lab. So, the accreditation, what we are expecting or what we are planning to do is something which will go beyond the degrees, the seniority, or the job titles in their workplace. And inspiration is drawn from ESHRI and Alpha framework, but we are trying, and we have tried to adapt it to our Indian clinical scenario and the regulatory realities. And last but not the least, we are a professional, non-commercial organization, and hence we are not planning to tie up with any vendors for conducting this accreditation program. Hence, I assure you that this is going to be a transparent and a fair program, which will actually help embryologists to identify or to know where they stand actually in terms of their skill and knowledge. With this, I would like to invite a team. Like, all this is possible by a team of 3 people, and many of them supporting from outside. We have Dr. Deven, Dr. Harsha, and Rashi, who are actively involved in creating all the finer points towards this accreditation program. So I now welcome Dr. Deven to give us more details about this accreditation program. Thank you. But before I close, I think before Dr. Deven starts, I also would like to acknowledge all our founder members and the past presidents of ACE. And it is their vision and it is their wish, which we, in this tenure, we are trying to make this into a reality. So I really would like to acknowledge all their work. Over to you, Dr. Deven.
Thank you, ma'am. So good evening, all delegates. So as ma'am has already explained, why accreditation is needed. So I will just give little more details. So why it is required. So as we already know, there are like ASHRAE exams, ASRM is there, even ASPIRE is taking this kind of exams, and they validate the skills of the embryologist and the competency levels also. So we are planning to have similar kind of exam for our India program, and this will help us to improve upon the skills, and throughout India it will be very it will be, the work will be more standardized, and the competency also will be standardized. As we know that people come from different colleges, or they get trained into different hospitals or the chains, they are having different SOPs, but still there is a requirement to have a proper accreditation certification for an embryologist, which is lacking here. So that is the reason we require this accreditation program. This will help us to build the trust within the community, that is the clinicians, and also within the patients. So that will help to build the trust within the community. Regarding the yeah, next slide, please. Arthi, next slide, please. Yeah. So what is the significance of this certificate once you achieve these certificates? So this will help you to standardize your practices. As already mentioned, that we are taking trainings in different institutions. Although there are different ways of working, but still it will standardize the techniques, and you will be able to know what different techniques are available and what are the best techniques to be used with the help of this kind of exams. Also, it will ensure the quality. So just for example, different SOPs are there, but yes, then with these SOPs you follow properly, then your KPIs will fall in place. And once the KPIs fall in place, obviously the success rate will fall in place. So this will help to have a very evenness within the centers also within India. Finally, there will be a professional recognition. So as we can see, like just for example, a batch of 20 embryologists are passing out from a particular institute. Out of that, maybe five has taken the exam, and out of five, three has passed this certification exam. So obviously, there is a professional recognition. They are little different compared to their colleagues or the peers. Also, there is a good career progression. So just for example, somebody wants to apply abroad with this kind of certification from a recognized body like ACE, that will definitely carry a weightage for the CV of that particular candidate. So it is very important that they take this kind of exam and then they do successful. They are successful in this, and definitely it will be a very helpful for them. And finally, coming to the regulatory compliances. So as we already know, since 2021, there is ART Act has been implemented in India. So we want that everybody should be knowing all this act, although people are following, but still there are some interpretations. So people are interpreting different way. Maybe this will help to bring everybody on the same page. Next slide, please. So what are the benefits of certified embryologist? So once the embryologist has passed this exam, so what are the benefits? So as I already mentioned, academic validation. So because you have already showed that kind of competency and you have passed the exam, so there is an academic validation. The career advancement. So for example, when I'm as a interviewer, when I'm having the 5 CVs, out of the one person is having some extra qualification certified from a very recognized university, obviously I will be little biased towards that person, that yes, this is what we require, the person who is having that skill and competency, which is better as compared to others. The peer recognition, I think I already explained the peer recognition, the continuous education. So once you are part of this ACE, then you will be having continuous learning also, the ACE webinars, the workshops, the recertification support. So that will be continuous education. It's not like single time exam and you will just take the certificate and go. You will be in continuous improvement part also. Mobility. So as I already explained, you are going abroad, then definitely this kind of certifications carry a weightage. And finally, the trust for the patient. So as already explained, once you have better SOPs, better KPIs, better success rate, then obviously the patient trust is definitely there, and that will bring in the clinician trust also. So these are the major benefits which we see once the enrollee is certified taking this exam. Next slide, please. So finally, what is the purpose of this accreditation exam, or what kind of journey you will go through when you will be taking these exams? So first, we will evaluate the theoretical knowledge. So you will be given the courses. I think Rashi will explain in detail. So then there are theoretical courses you will be taking, and then we will be taking exam of this theoretical knowledge. Then there will be certain hands-on competencies checks also will be there. So for senior level exam or level 2 exam, there will be practical exams also. So that will show the competency in practical way. Finally, QA/QC compliances are there. So just for example, we want error-free labs, zero error labs. So this kind of compliances and ART Act is there. So these all things will help you to understand. You go through all these details, and then you take up this exam. That will help you to understand the laws and QA/QC compliances in a better way. And finally, we will promote the ethical practices. So as I already explained, that error-free lab and proper implementation of the ART Act, that will help you to achieve once you take this exam. Now I will hand over to Harshaben for further details of the exam. Harshaben?
Sorry, I was muted. Thank you, Devin Bhai. We are proud to launch ACE Accreditation Examination, an initiative guided by our past presidents' vision of our leadership, ACE leadership, to raise the embryology standards in India. The next slide explains how to proceed for examination, what to submit, the fee structures, exam components, and application details. So ACE accreditation offers two levels. Level 1 focuses on core laboratory competition and routine embryology practice. Level 2 is designed for senior embryologists, emphasizing advanced skill, quality management, and leadership. Both levels are structured around defined roles, responsibilities, and competencies within the IVF laboratory. Next slide, please. Eligibility for ACE level 1 includes post-graduation qualification, master degree in clinical embryology or life sciences as per ART Act 2021. In addition, candidate must have minimum of 2 years of laboratory experience working as an assistant embryologist, ensuring adequate hands-on exposure before accreditation. All qualifications and experiences must be verifiable through official documentation in form of recognized institution and employers. Next slide, please. For ACE level 1 application, candidates are required to submit their educational degree certificates, relevant experience letter, and valid photo identification for verification. Next slide, please. The fees for level 1 is 6,000 Indian rupees plus applicable GST. This fee is non-refundable and covers document verification as well as the theory examination procedures. Next slide, please. So level 1 examination follows an MCQ based format. The exam duration is 2 hours. Comprising 150 questions. There is no negative marking and minimum score should be obtained 80% for passing. Next slide, please. So now level 2 examination, the eligible candidate accreditation is defined in accordance with the provisions of ART Act 2021. Ensuring the alignment with national regulatory standards for senior embryology practices. Next slide, please. The applicants required to submit essential documents including degree certificates, relevant experience letter, and duly maintained logbook with supervisor or clinician sign-off and valid photo identification. Next slide, please. The examination fees for level 2 exam is 12,000 Indian rupees plus applicable GST. The fees is non-refundable and includes document review, theory examination, practical assessment, and viva. Next slide, please. The level 2 examination includes a multiple choice written test for 2 hours with 150 questions. Minimum 80% mark is required to pass with no negative marking. Candidate must also clear the practical and hands-on skill assessment and viva examination. A minimum of 80% marks is mandatory in each component to qualify. The detail regarding application process will publish shortly on ACE website. Please stay tuned. I am handing over to the Rashi. Rashi will explain syllabus related issues. Rashi, over to you.
Thank you. So the syllabus of these examinations is broadly divided into 9 categories. We will focus on molecular and cell biology, genetics and reproduction, embryology, female reproduction, male reproduction, laboratory procedures, cryopreservation, laboratory and quality management, and finally ART and Surrogacy Act of 2021. Next slide, please. So the application process, as already mentioned, is available on will be available on the ACE website shortly. And in the meantime, if any of you have any queries related to the examination process or any details pertaining to the same, you all can write to us through WhatsApp or the email ID which is mentioned on the screen. Thank you so much.
Thank you so much, Dr. Sujata ma'am, Dr. Devin, Dr. Harsha, and Dr. Rashi for your crisp, informative, and well-structured presentations. These presentations have given us a comprehensive understanding of the thoughts, efforts, and the rigor that have gone into designing the ACE accreditation program. Kudos to you all. And with that, we now come to a very special and defining moment of today's program. I request our office bearers to please join the official launch of ACE Accreditation Examination Program along with our President, Dr. Sujata ma'am. May I invite our Vice President, Dr. Gaurav Majumdar, and our Secretary General of ACE, Dr. Parasuram Gopinath, to kindly proceed with the formal launch of ACE Accreditation Examination Program. Aarti, can we start the program? Aarti, next slide, please. Congratulations to the entire ACE team for this significant milestone, one of that will surely shape the future of clinical embryology in our country and across. Congratulations to everyone involved in this project. It's a big achievement for all of us. Thank you, team involved in designing this program. And with this important milestone achieved, we now move to the most awaited scientific highlight of the day. Today, we are extremely fortunate to have with us a scientist whose work has profoundly influenced how IVF laboratories function worldwide, and whose research formed the very foundation of modern embryo culture system, embryo assessment, grading, a name that every embryologist recognize and respect worldwide, none other than Professor Dr. David Gardner. He is not only an exceptional scientist, but also a remarkably polished and engaging orator, and above all, a wonderful, grounded human being. On a personal note, I still remember Professor Gardner's debate with Dr. Arthur Cheng at Aspire 2024 at Adelaide, marked by his calm authority, razor-sharp insights, and truly memorable mic drop moment, a closing that perfectly captured the power of his arguments. An inspiration to every embryologist, whether seasoned or just a beginning at their career journey in this field. Professor Gardner's presence with us today represents knowledge, leadership, and inspiration at the very highest level of embryology. This opportunity to hear him speak is not just rare, it is invaluable for every embryologist committed to the excellence. So, without much ado, to formally introduce today's distinguished speaker, it is my pleasure and privilege to invite our Treasurer of ACE, Dr. Rajvi Mehta ma'am, one of the most respected and pioneering embryologists in our country. So, over to you, ma'am.
So, thanks, Manisha. Dr. David Gardner has been very generous to give his time. It's late evening in Australia, and he'll be joining us soon. But I think this is a big event for us because ACE accreditation is something, and maybe before we launch, I would like Dr. Sujata to just give in a few words. She has introduced it. I'm sure I see a lot of youngsters in the crowd, and I'm sure they're looking forward to how it will help them. You see, today we have 40 plus universities possibly offering a master's in clinical embryology. The competition is going to be severe, and employers looking for young embryologists are also concerned about the quality of people trained in. And we hope that we can bring about a good match between the young embryologists and the employers. So, Sujata, a couple of words before Dr. Gardner joins in. Telling people about this. And if people have questions, please put it in the chat box. Even those on YouTube can put your questions there, and we will take it after Professor Gardner's talk.
So how is an accreditation important? See, we know that there are a lot of students coming out of this clinical embryology programs every year. But we also know that there are a set of clinicians who do not have any trust on the quality of people who are coming, who are freshly passed from these MSc courses. We always get to hear this feedback that they do not have experience. They have just passed out. So, but what we are trying to kind of put it across is the outcome in an IVF laboratory, it is just not, it wouldn't just depend on the qualification and the number of years of experience. It to a great extent would depend on the expertise, the skill level of a particular person, the understanding of subject, and the person's ability to make very critical decisions at times needed. Okay, so if somebody can certify and somebody can say that, like these people are there, like you can just, like trust them and then you can just employ them in your workplace. I think that would be a major help for the students who are passing out, because people, they thought that there are a lot of opportunities in the field of embryology, and then many of them are joining the course year on year, and then a lot of people are coming out. But if they are not getting an opportunity to work, now the whole program will collapse. So that is where now ACE decided, like people who are already working will anyway work. It is for people who are who have recently entered into this industry, who would need this. And then, like as a test of our own ability, people can, who have been working can also sit for this accreditation exam to see where we stand. Years ago, like more than 10 years ago, when I went and applied for the American Board of Bioanalysts certification, I realized like where all I need to strengthen my knowledge, what all things I need to know further. So this is kind of an education initiative also. So keeping this in mind, I think we should all uh, take this exam, encourage people to take this exam, so that, like we have a very standardized embryology workforce across this country. So that is the main reason for initiating this accreditation program. Anybody else want to say anything?
Now invite our Vice President, Dr. Gaurav, to say a few words, his thought behind initiating this program. Dr. Gaurav, please unmute yourself. Dr. Gaurav, please unmute yourself. Aarti, please help.
Thank you for unmuting me. And so I'd like to take this opportunity to congratulate all of you, Dr. Sujata, Dr. Rajvi, and the entire team, which has worked tirelessly uh, into bringing this ACE accreditation program, which is assessing embryologists and certifying embryologists. And so I really congratulate you. And this is a job of great responsibility, where now we have to, make this meaningful for the embryologists of our country, and so that they can reap benefits out of this certification. And I hope that this certification will be meaningful and will help all the embryologists for a much better future. That's all. Thank you.
Thanks,
Professor Gardner's here, so
Yes.
I will stop. Yeah.
Yes.
Yeah, we all are waiting.
So, firstly, welcome, Professor David Gardner. It is such a joy and a pleasure for us to have you here. I appreciate that you have taken time late in the evening, nearly night, to come to us to accept our invitation so that our embryologists would finish their basic work. I think everybody present here knows you. They know about you. Everybody, going back in time when we started sequential media, I know how much people struggled to get blastocysts. And it was 10%. And I remember reading your paper way back 25 years ago, half the embryologists possibly didn't exist then, that the sequential culture, it sort of was such a landmark that when we could culture embryos to blastocysts. And that's how we know you. And then later, I think every embryology starts grading embryos. And when they grade embryos, it's Gardner's criteria. Whichever criteria, it's Gardner's criteria. And I think we are full here. We had to shift a lot of our embryologists to YouTube because I think everybody was looking forward to just listen to you. They're very inspired by you. So I really appreciate you. Now, a formal introduction, because very often when we know a person for so long, you wonder whether the person is still active unless you're actively looking at their papers because you have become like a legend. So yes, he is truly a legend, but he's very, very active. He's a scientific director of Melbourne IVF. He's really an innovator and research director for Virtus Health, and a distinguished professional fellow at the University of Melbourne, Australia. I have very freely talked about his achievements, but there's much more that he has done. So if I go to the next slide and I will sort of talk about his other work that he's been doing. So Dr. Gardner has actually traveled across continents. So he started in UK, then he was in US where he did the sequential media work. And then subsequently, he went on to be there. He'd worked with John Biggers, he worked with Henry Lees. And, we had so many papers on Lees and Gardner talking about metabolism. Then later, he worked with another giant, John Biggers. And when he moved to Monash, Australia, another giant, Alan Trounsell, and now then he went back to the US working at the Colorado Center for Reproductive Medicine. That's where the sequential work came in. And later he's back in Australia and the professor and head of the zoology department of University of Melbourne. So here we have somebody who is innovator, who is a scientist, who is an academician, all filled in one. And with 41,000 citations. I mean, that just says it all, that one of the topmost in reproductive medicine. I think people would not like me just talking about your accolades, but they would rather like to listen to you. So over to you, Professor Gardner. And we just are really awed to have you here with us in India.
Well, all I can say is thank you so much for this very kind invitation. It really is an honor to be giving this talk to you all. Yes, I have been around a long time, Rafi. I have, but it's been a lot of fun. And I've had the pleasure, as you said, of working with some amazing people, both in the UK and America and here in Australia. So what I wanted to do today is I could talk to you about all that we've done. But as Ravi said, you can read that in the textbooks, you can read it in the papers. What I wanted to do today is talk about what we're doing now and what we're going to be doing in the future, because I think that's tremendously exciting. So I'm just going to share my slides with you. Here we go. And so you should be able to see. All right, you can see that okay, I hope?
Yes, we can.
Lovely. All right, so really, a lot of this talk is based on work that we've been doing over the last 5 years. And it's based on work that we're currently doing. And I'll talk about some of the future works that we're planning to do and that we want to do. And I hope it gives your students a great sense that you're all joining IVF, I think, and having been doing this for 42 years, I actually think right now is one of the most exciting times that I have ever lived and worked through. So I hope that gives you a bit of inspiration moving forward. And I'm also, spoiler alert, going to tell you that your jobs are not going to be replaced by robots. So that's some other good news for you. So these are my disclosures. This is my funding. And I'm also an advisor to 2 new companies here in Australia, Fertilis and Neogenics. And I am going to talk about some of their work because it's very, very exciting indeed. So before we talk about what we're going to do and what we've been doing, I think it's always important to remind ourselves where we're at and reflect a little bit on this slide. We're all familiar with the concepts present on this slide, which of course it conveys differences in morphogenics. So as the embryo progresses, you go from 1 to 2 to 4 to 8 morular blastocyst. And we can all see that, of course, the embryo is moving all the time. So it's not static, it's progressing through the female tract and enters the uterus around day 4, late day 3, day 4, at compaction. But what's really interesting from my perspective is that the embryo undergoes dramatic changes in its physiology. So if you think about the egg, it sits in the ovary for a very long time and can give rise to a viable pregnancy. Well, that's because it's adapted to doing very little. And the fertilized egg is very similar, has a very low metabolic rate and has very unique requirements. It can't use glucose like somatic cells. It needs to use pyruvic acid, some lactic acid, and indeed a few amino acids. By the time you get to the blastocyst stage, you've gone from a very quiet tissue to the most active tissue in the human body. It's incredibly active and it consumes a vast amount of glucose. It uses a lot of oxygen, but it has a very unique metabolism, produces a lot of lactic acid. And there's a good reason for all of the things that it does. And we've published extensively trying to explain why embryos do different things on different days. But the point I'm trying to get across is it's anything but static. Plus, there's an interaction between the embryo and its environment, and the mother's in direct communication at all times. So I guess we thought we knew a little bit about embryology, and then along came time-lapse, and that also gave us a great insight into what the embryo was doing on successive days of development. And I think it's really important because anybody coming into embryology today, this is their normal, right? It's like anybody who gets their first phone today, you get a smartphone. Well, several of us are old enough to remember life before smartphones. This is the smartphone of IVF. This is a complete game changer. And of course, we wouldn't go back to IVF without it. But it's still basically embryo culture as we used to know it, but we're taking images. So on the left, I've tried to convey the dynamics of life. And on the right is what we've been doing for the last 40, 50 years, which is we put embryos in a drop of culture medium in a Petri dish, or now you can use a specially created dish for your embryoscope or whichever time-lapse system you want to use. And pretty much that's it, which is fascinating because really we haven't changed very much in what we do. Now, for those of you who aren't familiar with this photograph, I know many of you will be, but on the left is Jean Purdy and on the right is Sir Professor Robert Edwards. And this was their laboratory back in the 1970s when they were trying to create life, the very first test tube baby. If you look behind Jean, just above her hand, you will see there's a glass jar. I first got to meet Edwards in 1983, and I went to Bourne Hall, and in his office was that glass jar. And I said to him, "Why, Bob, do you have a glass jar on your fireplace?" And he smiled and said, "David, my boy, we grew Louise in that." So that is what they grew Louise Brown in. It's a glass jar, but you could gas it and seal it. So basically it became an isolated incubator. And indeed, for the first probably 10 years of my research, both as a graduate student in York with Henry Lees and as a postdoc with John Biggers, we would use gas chambers because our incubators were really not very good. In less than 40 years, we've gone from that to that. So we have come a long way in terms of incubator technology. But really the fundamentals haven't changed though. We still grow embryos in a static system. We're just taking pictures every 10 minutes. And the embryoscope is a very, very well designed incubator, as a lot of the time-lapse are. So what can we expect in the future? So this is really the nuts and bolts of what I want to talk about. I want to talk about advances in biomimetics. These are devices that are designed to mirror what happens in vivo. I want to talk about microfabrication. This is some very new technology that has facilitated us to completely rethink how we do what we do in the laboratory, and I'll give you examples. Automation. Automation is coming. The degree to which is of much discussion, but automation of some parts of what we do is inevitable. And then I'm going to talk about how do we select embryos. I'll talk about biomarkers, because this is something that I've been fascinated with for a very long time. And then, of course, you can't have a talk about the future without talking about artificial intelligence. So I'm going to talk about all of these things. And then, so forgive me for the brevity, but there are lots of references for you, and I'm happy to send you PDFs as and if you need them. So why do we want to work on sperm selection? Well, the reality is we really haven't changed how we prepare a select sperm for 40 years. We do density gradient centrifugation, but the reality is that's a very effective way of purifying the sperm, but it has its problems. It generates reactive oxygen species and can induce DNA fragmentation. So it's something that we really need to consider. We also want to consider a way of isolating sperm with low DFI, low DNA fragmentation index, because we now know that a higher DFI can indeed run the risk of increasing miscarriage rates as well as potentially affecting normal embryo development. So what if we were to create devices that could in some way mirror the female tract? And in this way, when you look at a cross-section of the fallopian tube, you can see all these crypts and lumens. And this is where the sperm love to swim. They don't swim through like this diagram shows. They actually swim across the edges. And in particular, they love to swim in the lumens of the tract. So following on from that, we developed a biomimetic. It's a microfluidic device, but based upon many, many hundreds of channels upon which the sperm have to swim. So the sperm are actually placed on the outer side of this well, and they have to swim through microchannels. And through that, what we've found, not only do we standardize sperm preparation, it only takes about 15 minutes, is that we actually also, when we look at our data, we see that we are getting better quality sperm. And this is the paper we published earlier this year in RBM Online. And these are the data. So when we look at DNA fragmentation indices, this is the raw sperm prep, this is density gradient. But when we look at our microfluidic or biomimetic, we've reduced the DFI down to almost zero. Similarly, when we look at progressive motility, motility increases as we change from density gradient to microfluidic devices. So we do get very, very pure populations of sperm with very, very low levels of DFI. So we're now in the phase where we're using these kinds of devices in clinical studies. Our hope is that we see equivalent, if not higher, fertilization rates, but we see better embryo development with less pregnancy loss. Okay, now you can use microfluidics for lots and lots of things. And that's particularly relevant if you want to look for diagnostics, for example. And this is a review we published a couple of years ago in Nature Reviews, whereby we predicted that semen diagnosis would actually be scaled down to just one chip. And you could place your raw semen onto these chips, and onto that chip, because it's microfluidic, you could separate out various facets of the chip to do various facets of diagnostics, which is fascinating. So again, leading to, you load your semen onto one chip, it goes into the reader, and you get a whole range of outputs from CASA to immune capture. So all of these things are coming, which is fascinating. All right, I want to talk now about a thing called microfabrication leading to a technology called microperfusion. So this is a review I wrote in 1994. And you can tell by its title, it says mammalian embryo culture in the absence of serum or somatic cell support. So in 1994, as was discussed in the introduction, we really couldn't grow embryos very well at all. So this was really a projection paper based on a lot of basic research I'd done, looking to the future of how we were going to take serum out of culture media, how we were going to move away from co-culture, which was the somatic cell support. And I predicted in 1994 that the future of IVF would be moving to single blastocyst transfer with embryo biopsy. So that bit was right. But the way I predicted it would be done wasn't, and this is what I predicted. I predicted that we would be growing embryos in a perfusion system. So rather than have embryos just sitting in a static drop, we'd be able to perfuse culture media across the embryos and therefore recreate somewhat the dynamics of the female reproductive tract. But more than that, we could take samples of the spent culture medium and perform biomarker analysis on. And of course, you could image the embryos. So all this was in 1994. The problem with this was the technology to do that just didn't exist. There've been many attempts to do this over the intervening decades, but really none very successful. But all that changed a few years ago when a colleague of mine, Jeremy Thompson, was on sabbatical with me. And Jeremy was interested in using microfabrication to create new devices. And this is a technology using 2-photon polymerization lithography. whereby you use lasers, dual lasers, to actually print in liquid at the sub-micron resolution. So it's not like your regular 3D printing. This is sub-micron resolution 3D printing. So if you look at this as a printed Eiffel Tower, that's 100 micrometers. So you could actually tell that this is just smaller than a human egg. But if you can look at the resolution of the tower, it's incredible. And then when you look at the teapot, the gecko, and the bull, this is 1 micron, 1 micron. So these devices are smaller than a sperm tail. So this is the level of definition we can get. So with this, we decided to start creating devices that we could use in embryology. And the first thing we wanted to do is create an embryo perfusion system. And then to do this, what we decided was to put embryos inside a 3D device called the cradle. So this is like a universal carrier. We could 3D print these devices. I know they look like Lego, but actually they're 3D printed. And these are actually mouse embryos just here. You can load the embryos into these cradles and they get docked into a garage. And the garage is perfusion ready. You can attach all the devices to perfusion tubing. So that was the first proof of principle. We were able to co-create a non-toxic polymer to make all these devices in. And like I said, it had built-in perfusion capability. That was the first iteration. 2 years ago now, in Scientific Reports, we published the engineering that went into all of this into a nanoliter perfusion system, whereby we can actually culture embryos in a real-time perfusion at the nanoliter level. So it really is mimicking kind of the flow rates that would occur inside the female tract. So I'm going to show you a couple of videos, and you'll see that we have our device in the cradle, and now we dock it into a nest. And we're able, by simply turning the medium on and off, to actually agitate the embryo. And it turns out that that's a really important point in embryo development, by moving the embryos. So this is what it looks like now. We can actually take our cradles and dock them into a nest here, and then this is all perfusion ready. So it gets docked, and now we can actually pass culture medium over it. All right, it all looks so simple. But this is what it looks like down the microscope. So we've used food dye, so you can see the perfusion coming across the red dye. When I press the video, the embryos, the pump is on, but when the pump is turned off, the embryos will move. So we can facilitate agitation. And then you'll see the culture medium coming across the embryo. So the medium's on, the pump is on, pump goes off, and the embryos move. And then in about 5 seconds, we turn the pump back on, and the embryos move back on again. And then you'll see flow of the medium going across the embryos. Pump on, there we go. And so they move. So we have two things that are beneficial to the embryo development: embryo movement and a dynamic culture. So this is 23 years in the making. This is really a 30-year study. This is something we started 30 years ago, and we have now managed to do. So for those of you who are just starting out, it pays to be persistent, because perseverance pays off. Okay. And in the future, this is something that we hope we could be able to do with this technology, is create individual culture media. So instead of being personalized medicine, it's embryo personalized. So you can grow embryos individually, you could monitor their needs, and then you could create culture environments that mimic the needs of that particular embryo. So that's somewhere off into the future. I think that's 3 to 5 years away. But these kind of technologies are here now. So that's the exciting thing. All right, talk about intracytoplasmic sperm injection. This was obviously a landmark, 1992, when Jean Pierrot and the team did the world's first ICSI in the human. And it really circumvented male infertility and changed everything. But since then, not a lot has changed. Of course, piezo has come about. Piezo has actually been around for a long time. It's only quite recently that it's been used clinically. And I think the Japanese group, Shiatani, have done exceptionally well at optimizing how we do piezo. So that has potential. What we thought about was actually changing how we do ICSI from a different perspective. And so because we could fabricate nano devices using the 3D printing, we created a device to replace the holding pipette. So if you think about the holding pipette in an ICSI, the egg has to absorb all the pressure of the needle itself as the needle comes in. And you can always see the suction here that the holding pipette is putting on the egg. So there's a lot of stress being placed on the egg, both from the ICSI needle, the egg has to absorb it, and from the holding pipette. It works, but it is inducing a lot of cytoplasmic deformation and stress. That's clear for all of us to see. So what we wanted to do was create a device that could help the egg absorb the pressure. And this is what we came up with. It's a device, 3D printed device, and it's basically like an egg cup. And you can see that the egg cup itself actually starts to absorb a lot of the pressure from the needle into the egg. It also means that you only need one micromanipulator because these devices are printed into the dish. So ergonomically, what we found is that it takes less time to perform ICSI, and you're moving your body a lot less. Now, why that's important is one of the things that we are very conscious of is that embryologists who do a lot of micromanipulation over time can actually get recurrent strain injuries. So if we could do anything to improve the efficiency and efficacy of the techniques that we use in our lab, it's going to change how we do things. So this one, as you can see, the time to inject is significantly less using a 3D printed device, and the number of handling adjustments, in other words, how many times your hands have to move across the micromanipulators, is more than halved, which is impressive. This is the device printed onto a dish, and you can see we have numbered arrays, so you can actually load, in this case, up to 20 arrays. This is the PVP, this is the sperm, and you can go straight in and do your injections of your egg. I can tell you that we have now got our first paper coming out. It's in Press in CERM, whereby we show in sham injections that this approach actually induces less change, conformational change in human eggs, which is particularly exciting. Okay, what about blastocyst biopsy? This is something that's been done more and more worldwide as PGT grows. Again, historically, this is how we've done it. We've had a holding pipette, the same holding pipette, slightly bigger to hold the embryo. And then there are various forms of using laser-assisted ablation or flicking the embryo against the holding pipette. We're all familiar with that, but it's all very technician dependent. It takes quite a bit of time, and it's very demanding on your embryos. So this is the classic flick, whereby you hold the blastocyst there, you move it over, and then you drag it across. We thought surely we could do something more unique than that. So we created a 3D device called microbiopsy. In this, we put our embryos inside a 3D printed chamber, but what we have printed is a very fine cutting edge. So rather than have to try and flick the trophectoderm across the pipette, we can actually just drag it across a blade. So I want to show you what that looks like, because it is quite remarkable. So this is actually a mouse embryo. This is the trophectoderm coming out, and we're going to drag the embryo across just to show you how quickly biopsy takes place. Done. And for anybody who's been doing biopsy for a long time, including myself, you'll realize that that is a complete game changer. So now we're introducing that in clinical studies across the world. So this is particularly exciting because it's going to reduce the time it takes to do an individual biopsy, and it's going to standardize how we do it. So I hope you get in the presence of mind that we're trying to implement technologies that will improve what we do, but it will make it more repeatable from embryologist to embryologist. What about microrobotics? This has been around for quite some time, and these guys with Bob Casper were the first to show that you could actually use robotic ICSI. And this is a long time ago now, 2011. Very detailed engineering. We've come quite a way since then, and now we're familiar with the technologies pioneered out of the Conceivable Life Group and Jacques Cohen and Alejandro and his team, what they've been doing to look at digitally controlled, remotely operated ICSI, leading to complete robotics of what we do, which is really fascinating technology. So far, they've been able to automate a lot of what we do in an ICSI, but they still can't automate oocyte denudation, sperm prep, 60 dish prep. So there's quite a few things waiting to be done, but it's very impressive what they can automate. And I'm going to come back to that in a little minute. But this is an important paper, came out 3 years ago from the UK. And it was documenting occupational health injuries in embryologists, because what we do is so intensive, and often we're doing it for hours and hours on end. This is another reason that we wanted to develop a lot of these new technologies that will reduce the time it takes to do a task, because it'll be much easier on the body, and therefore keep our embryologists, keep us doing what we do for much, much longer without having to take time off work being sick. So I think that's a really important point, is to prevent burnout in embryologists. All right, now I'll just shift gear about talking about selecting embryos. What's the best way to select an embryo? Over time, we've got very good at looking at embryos. And this is a review that I wrote with a dear friend and colleague, Bashek Balabin, gosh, nearly 10 years ago now. And we've been able, over the many years, to create grading systems for the fertilized egg all the way through to the blastocyst. And they've really stood the test of time. They've really been very important. But no matter how good your grading system is, no matter how good your time-lapse system is, which is basically grading an embryo but frequently, that's all we're doing. We're just looking at embryos. Now, we can get a lot of information, but I think if you went to your doctor's checkup and all the doctor said was, wow, you look great, I think you'd be a bit worried that you're not going to listen to my heart, take a blood sample, do something. But in essence, in IVF, that's all we do. We look at the embryo and go, wow, you look great. So what more can we do? Well, we can actually do quite a lot more. And one of the things that I've been focused on since the start of my career is metabolism of the embryo. I'm interested in it for two reasons. Number one, as I alluded to, the embryo itself changes on every day what it's doing. So it's a fascinating thing to study. It really is a fascinating thing to study. I think most people think of embryo metabolism and they get a little scared or think back to their biochemistry as undergraduates. It really is a very cool part of embryology. And maybe you'll invite me back on another time and I'll talk to you just about the metabolism of the embryo, and I'll convince you that it's really a very exciting field. But we have a lot of technologies to look at the metabolism of embryos. We can look at spent culture medium. In the old days, we used to use radioisotopes. We used to use different types of, whether it was tritium or carbon, and label the various sugars. And we could use scintillation counting and look at where and what the embryo was using. Obviously, we can't do that clinically because we can't use radioactive tracers. But what we could do is do spent medium analysis, but also we could also look at autofluorescence. I'll now come back to that. So this is one of my very first papers in 1987, where I was able to demonstrate there was a relationship between glucose uptake by a mouse blastocyst and its ability to derive a pregnancy. So this is from a book chapter Henry and I wrote a long time ago. But in essence, all this time, there's certain labs around the world that can actually measure single cell metabolism. That means looking at the uptake of nutrients and the release of metabolites. And by doing them in combination, you can get an indirect measure of metabolic pathway activity. And of course, now there's been a lot of talk about exosomes, microRNAs, and of course, non-invasive PGT. But I'm not going to talk about those. I'm going to focus on metabolism. This is a study by one of our graduate students a few years ago, Laura. What Laura was able to do was confirm a lot of our previous studies by showing that glucose uptake by human blastocysts is related to their ability to form a pregnancy. So the higher the glucose uptake, the more active the blastocyst is, the more likely it is to give you a pregnancy. Laura went on to correlate that with their morphology, their morphokinetics, their KID score, and we also used artificial intelligence. She was able to show that when she looked at amino acid utilization between blastocysts of different AI scores, they behaved differently. So it was a really fascinating study, but it did reinforce that metabolism is a very useful biomarker. The downside is to do these kinds of analysis, whether it's nutrient uptake such as carbohydrates or amino acid turnover, you need highly specialized equipment. And to do the amino acids, you typically need a mass spec. So we're talking about pieces of equipment that can run up to $500,000. So way beyond the budget of an IVF clinic to want to invest in these kinds of technologies. So how can we get around this? Because this was data collected from spent medium analysis. Well, possibly one of the ways we'll be able to do it is actually with light. And there are several new microscopies that will help us get there. I have to do a big shout out for optical coherence microscopy. Optical coherence is going to give you the opportunity to look inside the embryos. And there's some new companies coming out that are developing some really great optical coherence with AI, which means you can actually, for example, inside of the COC, you can actually visualize the maturity of the egg. You can tell if it's a GV, M1, M2 without getting rid of the cumulus, because the optical coherence lets you see inside of things. But back to metabolism. I want to talk about autofluorescence. Now, when you look inside a cell, cells have all of these things inside them: amino acids, collagen, elastin. These are, of course, metabolic cofactors and intermediates, vitamins, you name it. The reality is each of them has a separate excitation maxima and a different emission maxima. So as you use different wavelengths to scan a cell, you can actually start to identify several of these different components of the cell. Now, to us as metabolic people, we are really fascinated in this group here, because this reflects both oxidative and cytosolic, so mitochondrial and cytosolic metabolic functions. So this is what it looks like. This is inside some fibroblasts, and using different wavelengths, you can, in this case, look at the relative abundance of NADPH. That's really, really important for assessing metabolic state. So one technology that came about was fluorescence lifetime imaging, and this is from a paper by Denny Sakis' team in Boston. And what they're interested in this case is looking at nicotine adenine dinucleotide, NAD or NADH, which is primarily used in glycolysis. And so this is the panel where they can visualize where this is. And you can see it's throughout the cytosol, whereas flavin adenine dinucleotide is a mitochondrial fluorochrome and coenzyme. And you can see it's more punctate and sporadic, and it's clustered within the mitochondria. So using these different microscopies and using different wavelength microscopies, you can actually start to build up a picture of metabolic functions just using light. So that's fascinating in itself, but now I want to introduce you to another term, which is called aneuploid stress. So if you have a somatic cell, let's not say embryonic, just a somatic cell, and it exhibits aneuploidy, then that cell will have an altered karyotype, which will mean an altered transcriptome leading to an altered proteome, leading to an altered metabolic state, different phenotype. This is referred to as aneuploid stress. I've not really heard about this in the terms of IVF before, so I really was very keen to introduce it back in 2019. In 2021, Kylie Dunning's group in Adelaide here in Australia used a different microscopy. It's called hyperspectral. And hyperspectral, just as you can imagine, uses many different wavelengths of light to excite cells and then quantitate their emission. In this case, these are human fibroblasts, which were either euploid or aneuploid. And what Kylie was able to do was show quite clearly is that aneuploid fibroblasts have a different metabolic phenotype than euploid. So this was really, really interesting. This was then followed by two papers by Denny Sakis in Boston, which was showing that you could use a different type of light microscopy called FLIM, fluorescence lifetime imaging, but a similar technology because you could get metabolic and data, and both of which showed that you could actually detect differences between euploid and aneuploid embryos based on their spectral emission, which is fascinating. So potentially, and I'll come back to it in the end, we'll be able to use light to quantitate metabolic state, which would be fascinating. Okay, I'll move on now to artificial intelligence, because you can't talk about the future without AI. I'm going to start by talking about sperm. This was a landmark paper in 2019, so much so that it got its own editorial in fertility and sterility. And the significance of this is that these guys were able to use AI to quantitate the morphology of sperm using WHO criteria. So it really is a very, very important piece of work. Since then, there are companies that have evolved into trying to identify viable sperm for both ICSI and insemination. So we're going to see a rise of AI helping us to identify sperm based on morphology, as we currently know, but perhaps in the future based on other criteria. This is one of our graduate students, Dale, and Dale was involved in developing another artificial intelligence, but in this case, it was to find sperm in azoospermic samples from testis biopsies. As you know, as a busy lab, the worst thing you have is you've got your week planned, you've got tomorrow planned, and then you find out that several of your cases tomorrow are going to be a testis biopsy. And then your whole day goes, because you know very well you're going to have to roster 2 or 3 embryologists finding sperm for hours and hours. And it's really important to get the sperm out of there as quick as possible, because obviously the longer you leave them in the tissue extract, the worse they're going to get. And so we felt that this was something very important to focus on. So we developed this technology to actually identify sperm within a biopsy sample. And what we've been able to show is that we can reduce the time to find sperm dramatically. And in fact, we've been able to find sperm in biopsies that we as humans couldn't actually find. So this is a technology that now is going out and being trialed around the world as we speak. So that's the sperm. I'm sure you're familiar with this work by Julian's team in Canada, Future Fertility, using AI to assess the developmental competence of oocytes. As we move more and more to oocyte cryopreservation or oocyte donation, it's more important than ever that we're able to quantitate the developmental potential of a cohort of eggs so we can tell our patients their chances in real terms. So I think this is going to be a really big part of our future. Okay, looking at embryology, it's interesting still to this day when you go to a conference, the majority of AI talks and papers that have been published have been trying to look at embryo grading. So this was the first, and I was delighted to be part of a team that developed an AI to actually help assess human embryos. This technology was then sold from our group, the Virtus group, to Vitrolife. And Vitrolife then went on to develop a further iteration of this, and this became the IDA score. And this IDA score is endemic and built into all the embryoscopes. So does it really work? There are lots of great data, lots of interesting studies that they show you areas under the curve. And they all look very impressive. What we wanted to know is, actually, does it work? So we undertook a prospective randomized double-blinded non-inferiority trial to see whether AI was as effective as a human embryologist. And what we were able to show is that whereas AI significantly reduced the time it took to do the grading, we could not prove non-inferiority. So it's interesting that there are clear benefits, but what was also interesting is that during the trial, which if you're doing a prospective randomized trial, these things take a long time and a lot of planning. Halfway through the trial, the technology we were using was superseded by the next iteration of AI. So by the time we'd finished the study, the technology, the AI we were using wasn't being used anymore. It was the next generation. So I think we learned a valuable lesson in this, is that we have to think of better ways of assessing new technologies. Prospective randomized trials just take too long, and technology is going so fast. So I think it's pretty much, a lot of people now are in agreement that we have to come and consider new ways of assessing new technologies. But what I think AI could be very useful for is KPI monitoring, looking how we're all performing, how our labs perform, how our embryologists are performing, but do it in real time, get positive real-time feedback on functionality within the lab. I think that's a very exciting potential of it. So I think then if you take all of this and put it together, and this is a review that we put out a few years ago, where we felt it was very important not only to reduce time to pregnancy, but we wanted the birth of a healthy child. And we predict that the way we'll do that is through these kinds of functional analysis of the embryo. So here's our embryo sitting in the microfluidic culture device that's been 3D printed. We can perfuse it, we can measure through biomarkers or through light. The microscopies we have include time-lapse, optical coherence, or hyperspectral, so we can truly get an incredible amount of morphological and metabolic data from a single cell. We can then put this through our various image analysis and biomarker analysis, but we will create so much information for our embryo that only artificial intelligence will be able to help us create a health score of that particular embryo. So in conclusion, microfluidics is an excellent platform for creating and developing new sperm diagnostics and preparation technologies. They will standardize what we do. They're very quick, they're very efficient, they're very cheap. But being a biomimetic, it also means that not only will we improve how we do it, we will get healthier sperm out at the other end. Microfabrication has been a Pandora's box. We can now make devices to do things in the IVF lab. We can make egg cups to hold eggs during ICSI. We can make biopsy tools. We can make perfusion systems. All of the things that we could have only dreamed of even 5 years ago, we can now do. And a lot of these things are currently being evaluated in trials. Now, microrobotics potentially can standardize some of what we do. But it's interesting that the way a lot of people proposing robotics are saying that they're going to replace embryologists with robots. I don't see that happening. I see that in the long term, we will have some robots. I hope they're in the back making my culture dishes. But I think it's more likely over the next 5 to 10 years, what we'll see is a different approach, which is the approach I've articulated, which is using specially created devices to augment what we do as clinical embryologists. So as I said, these new devices will help improve our efficiency and standardization. It's not just good for the embryos, it's good for the embryologists. Analyzing spent culture media is a very exciting way of predicting the viability of an embryo. If we could do it through light, that would be sensational. It'd be so much quicker and we could standardize it. And these technologies are here. We're not talking about things to come. I'm talking about all of these technologies that exist at present. And I think AI provides us this great opportunity, but not just how to score an embryo. I think its power will be how can we find the best sperm, how can we find the best egg and make the best embryo from the gametes we've got. If you start off with the best gametes, you're going to make the best embryo. But I think AI can do so much more in our IVF labs than just simply pick which embryo for transfer. So finally, it's going to be evident that through some parts of automation, our jobs are going to become more streamlined and more efficient. But I don't for a minute believe that any embryologist will lose their job to this, because what I believe will happen is because we'll become more efficient and more effective, we'll be able to increase the number of cycles a given embryologist can handle, which is important because there's an ever increasing demand for IVF. So currently, if one embryologist can do 100 cycles, perhaps in the future that can double, which is great because now we'll have a higher throughput of patients. We can get IVF to those people who need it, but we're able to do it in a much more streamlined fashion. So we have this endless discussion as well about human intelligence and artificial intelligence. And it kind of amuses me that people see them as antagonistic, when actually they're synergistic. If you talk to AI engineers, they will actually say that human intelligence, human cognition is so different from artificial intelligence that there are synergies and actually the two work best together. And so these two papers, one from Japan, when they analyzed the ability to use AI or embryologists, they showed that actually it was better when you use the two together. And Charlie Borman in Boston actually then repeated this, and I love this paper's title, Should There Be an AI in Team? And of course the answer is yes, because the incorporation of the AI framework enhanced the performance of trained embryologists. So in the future, rather than seeing this, I think we're really looking at the connection of the two. I do not believe that embryologists will be replaced by AI and robots. However, I do believe that embryologists will be replaced by embryologists who do use AI and robots. So the message really is change is inevitable. It's coming very quickly, but embrace it, because it's not there to replace what you do as an embryologist. It's there to augment what we do collectively and make better outcomes for our patients and make our lives more efficient. I'll close with this. This is my very last slide. 3 years ago, I was asked to write this countercurrent for the journal Reproductive Biomedicine Online. And basically what it was about was to say the way to improve IVF was to introduce more technologies. This year, on the anniversary of RBM Online and Bob Edwards' centenary, I was asked to write another article, and I called it IVF Through the Looking Glass. Again, it was really looking to the future of IVF. But what amazed me is in the 3 years between these two papers, how far the technologies had come in just 3 years. So when you go back and read the 22, then I look at the 25 paper, it really is impressive how far we have come in 3. So I'm really excited to see how far we're going to go in the next 3 to 5 years. It's going to be amazing, that's for sure. So, ladies and gentlemen, that's my opinion, and it is very much my perspective on what I think is going to happen in the next few years in human IVF and in your laboratories. Thank you.
Thank you, Professor Gardner. That was a fascinating 45 minutes. I mean, it gives us a totally different perspective, because when people talk of future of IVF, the thoughts are automation and AI. And you brought in a lot of technology. I mean, the fact is that using 3D to create all these devices is fascinating.
Yeah,
And
absolutely.
and the whole concept of standardization, people try to standardize, we want consistency, but the way you brought it and the fact about using optics, I mean, to get the fluorescent images using this technology. And what really I believe that, somebody you've been there in the field for nearly 4 decades now or more, you are even considering the health of the embryologist, and
Yeah.
how you can make things easier so they can continue giving their best. So I think it was a very fascinating talk, and it's not just the 45 minutes, but I think people will need to listen to it again and again. So many new thoughts put in. One question that a lot of people are going to ask is how much of this would be seen soon in the near future? Because it's very rational, logical.
Yep, it is. And I'm convinced that we're going to see some of these technologies within the next 24 months. I mean, I'm not talking, I used to think years, but some of these new devices that we're working on, I think we'll have them available in the next 24 months to play with and actually use in clinical cases. So all of these technologies are coming so fast. It's a super exciting time. Yeah.
You did mention about the randomized controlled trials and that being a very slow process.
Yeah.
Even when it comes to introducing new technologies, if we use the same old methods of assessing and evaluating, would we be slowing down this entire journey and process?
Yeah, I think we would. I think we've got to develop new ways of doing clinical evaluations. And I'm not alone. I know many people, including Bart Fauser, the past editor of the journal RBM Online, whether that's cohort studies or what we do. But doing prospective randomized trials is very time consuming. It costs a lot of money. That's not a reason not to do it. The reason is that often the technology, it takes so long, the technology that you're testing is redundant by the end of it. And I think that's true more so for AI. Obviously, if you developed a culture medium, that's slightly different. But I think if you're looking at these new technologies that are very fast to emerge and they're continuing to improve, that's going to take some doing. Yeah.
So how would one assess these technologies? Because, there has always been this conflict to take in new technology, and are we going in the right direction? Are we rushing in?
Sure.
How does one assess it?
Yeah, and I think a lot of these new technologies are really it's not giving us, it's not necessarily challenging us to bring something completely new into the lab. It's saying, look, this is how you do something. Why don't you try doing it this way? And I think then you'll realize, you go, oh, it's a bit like saying I drive a manual car and then we bring in an automatic car. You say, why don't you try the automatic? I don't want to. But yeah, no, when you explain how to drive it, you drive the automatic and you go, oh, that was nice. I quite like that. Right? Now, did you do a trial? No, you test drove it. So in a similar way, if you know that the outcomes are the same, but much easier to do one way. So for example, with the ICSI device, if you find that you take half the time to do an ICSI by doing it using these 3D printed, basically egg cups, and you're getting better embryos, well, you're well on the way to being a convert because you're just replacing a holding pipette with a new device. Clearly, we want to see studies done, but what I would say is that it's just getting to the point with a lot of technologies, it's just going to be harder to do. Yeah.
So I know there will be a lot of questions, but I also know it's nearing 9:30 at night.
It
So
is
we
now.
won't take
Done.
yeah. So I'll ask Dr. Sujata, the president of our Academy of Clinical Embryologists, to put in. She had a couple of questions, and
Sure.
there has been one very simple question: what
Oh,
happens
no.
to conventional IVF? That's what somebody has asked.
Oh,
You know,
conventional
that's a
IVF.
Yes.
Right. Well, that's a very good question. Right now, that's staying. You know, actually, but I think here's the thing: is if we do use AI to help us prepare, or microfluidic devices to help us prepare healthier sperm, the first thing that you're going to say is that we don't need to inseminate with as many sperm. So and that might sound obvious, but it is a change to what we do. You know, what we do is kind of dogma, isn't it? I mean, you and I have been doing this so long. We have our playbook and we go to it.
Yes.
But every now and then you go and say, but why do we do that? Well, we say, well, we've always done it. But if you can say, but actually now we can show that the sperm are healthier, you don't need as many. Oh, that's a good point. Well, that might reduce polyspermy. Actually, it might reduce the time we need to inseminate the eggs. So all of our processes, it's like a challenge. What I say to everybody, especially the members of our team, is I'm going to challenge you and I want you to challenge me back. Is this the best way to do anything? And it becomes quite a fun environment when you have a very positive mindset about questioning what we do.
Okay, Sujata, over to you. You have the last question and then we can wind up.
So thank you very much, Professor Gardner. This is a surreal moment for us, to hear about the future of IVF laboratory from you. So the one question I had is it going to make IVF expensive?
No. That's the reality. None of these things should really make it more expensive.
Because
no, I think that's because we're replacing pieces of equipment that we use with just new surrogate pieces of equipment. We're not introducing more technologies. Certainly, artificial intelligence could add cost. I mean, that is feasible. But overall, because we're going to be reducing the time it takes, so there may be more cost in an AI license. There may be more cost for a piece of new technology, but it'll make us more efficient and therefore it'll take less time. So there'll be savings on the embryologists. So I think overall it comes out in the wash. There might be more investment in equipment or a consumable, but less hours to do a process. But I don't see it as making it even more expensive, too much at least.
in a country like ours, where the cycles are 100% paid by the patients,
Yes.
we are kind of caught in a vicious circle. So, one, for example, if we have to implement AI-based embryo selection, we have to put the cost on the patient or the clinic has to take it. And then the question asked is, okay, I'm ready to pay so much, but is it going to guarantee me a pregnancy?
Yeah.
When we don't have an answer for that, then we start enthusiastically and we kind of drop that, instead of going forward.
Sure. Yeah.
So what do you think, like, what is the way out for this?
I think the reality is that all patients have is hope. And the one thing we don't want to give them is false hope. So the more information we can provide them, they can make more informed decisions. And for AI and embryo selection, for example, trying to stack the deck in the favor of finding that one embryo that's the lead in that pack, that's got the best chance, is just reducing time to pregnancy. So there are inherent values, but it's really how you sort of pitch it to them. Now, in Australia, we don't use AI to make that decision for transfer. We make the decision. We Gardner grade everything. But what we will do is if we have patients with 2 or 3 embryos with the same Gardner grade, then we'll go to the AI and say, rank them. So the AI will then say, okay, you've said this, but I'll give you 1, 2, and 3. So that's great. And I think that's where it has its place. But it's not just because I created it, but I think the Gardner grading system has managed to hold its head high for 20 odd years, and it still works very well. So, but it's subjective. That's the other problem. So AI gives you the objectivity, and it takes away the variability that you have. I have a joke, which is, when is a 4AA blastocyst not a 4AA blastocyst? And the answer is when it's scored by your friend, not you. So I think that's the point I wanted to make. Right. With that, it's rather late here, so I am going to say farewell. I wanted to wish you all the very best on this wonderful initiative that you've got going. It's a pleasure to talk to you all. It really is.
Thank you. Thank you so much.
Thank you very much. Thank you.
You're welcome.
Good night.
Thank you so much, Professor Gardner, for such
You're welcome.
an insightful and forward-looking lecture. Your perspective on future IVF laboratory have given all of us valuable directions and inspiration. I had privilege hearing you many times, but I especially remember Adelaide Moment, your legendary debate with Dr. Arthur Chan, your
Oh, yes.
authoritative, authority, razor sharp insight, and especially that legendary mic drop moment. These memories are still with me.
Thank you. That was a very good
forever.
day. Thank you. That's very kind. All right.
Listening to you is always a privilege, and his lecture has once again left us inspired and thoughtful about the future we are building as an embryologist. We are truly grateful for your presence with us. We are truly grateful for your time and sharing your immense expertise with us. Thank you once again, Rajvi ma'am, Sujata ma'am, all the office bearers, and for this wonderful session. And may I ask a quick question on behalf of all embryologists? What expertise you would like us to develop to be efficient or relevant in time of AI as an embryologist?
What ambition did you say?
Actually, I really wanted to ask, what one skill or mindset do you believe future embryologists must develop today to remain relevant and impact the IVF laboratories of tomorrow?
Thank you. That is a very good question. So, number one, never lose your childlike love and curiosity about this is something spectacular. That first slide, we had 1 cell, 5 days later is 100 cells with 2 cell types in it. I never, ever get bored of looking at an embryo, ever. Every day, I start my day about 7:30 in the lab, and I just look at embryos. And it gives me a sense of calm. And a sense of wonder and awe that we are privileged to be seeing life in its very first few days. And that is a great humbling thing. If I may give you one piece of advice, which Bob Edwards gave to me when I was a very young man, the other thing is stay curious outside of your field. Don't just read embryo papers. If you can read papers in other aspects of biology, you often find overlaps in systems. And that has served me well for 40 years, that piece of advice. And it provided me to be able to see embryos in a way that maybe other people couldn't. And it's only because I went outside of my comfort zone and I was reading literature on cancers or neural tissue, plasticity, nutrition, all kinds of things. It gets harder and harder because as you become clinical embryologist, the demands on your time are immense, and I respect that. But if you do ever get the chance, do follow, try to read a little bit outside of reproduction, because it's all related. It's fascinating. Life is a miracle, and that's all I can say on that. Great. Thank you.
Thank you so much,
Thank
sir.
you.
To have
You're
been
welcome.
this
night.
long memorable.
Thank you.
So
Bye.
Thank you.
with this,
Bye.
may I request our Vice President of ACE, Dr. Gaurav Majumdar, to
I-
conclude the session with both of
I
them.
think we can let Professor Gardner leave. I think
Okay,
he's been
I gotta go.
wanting to
Thank you.
leave.
Thank you.
Right.
Thank you.
Yeah, bye-bye.
Good night.
Good night.
Good night. So over to you, Dr. Gaurav. You are muted, sir. Dr. Gaurav, you have to unmute yourself.
Yeah, I've unmuted myself. Why don't we ask Dr. Parshuram? Is he here?
Yes,
Yeah, I'm
he's
here.
there.
Yeah. So he's going to give the vote of thanks, Parshu.
All right. I think so. Let me conclude this.
Yeah, just a minute, Parsu. I think we'll need to tell them that what we started this, the accreditation thing, is as exciting as Gardner's work. And you're going to take it forward being the secretary.
Yes.
So yeah, your concluding remarks on that.
So to begin with, I think we had a very exciting session, and somebody to listen to somebody whom we have looked up to, understood, listened to every word that he speak about, and I think it has been quite exciting. Another interesting fact again is, yes, today there have been technologies. So I did ask that question because I did not want to interrupt in between, because when everything is fed to you, are we still going to be the real embryologists that we are today, where we will continue to think and do the things, or rather just being fed with just the data and we keep continuing to do it? How do we improve people? Like what Naval asked in the group, will we ever have another Gardner when everything is fed to you, when there's nobody to think about? So I think these are all interesting aspects to the talk today. And the highlight of today, more importantly, which I feel is more than Gardner, is this our accreditation program. I think a huge congratulations to all our office bearers, our past presidents, the initial founding members of ACE who had actually thought of it. And Dr. Sujata took up the initiative to actually start doing this when our term started. And I'm truly honored and privileged that I also was a small part of this, being the secretary of the society at this point of time. And I think it's going to be a landmark event. And I think it's going to help a lot of embryologists, because I think, never valued our own association till we started getting letters from different people asking us to validate and approve these people who are embryologists from India. And we understood that probably, yes, we as an association, as an association of embryologists for the embryologists, by the embryologists, should also play some role in making sure that we provide some form of accreditation. And so huge congratulations to the team, Harsha Ben, Deven, Rashi, under the leadership of Dr. Sujata, to actually come out with this. I think this is only just the beginning. We are starting with a very basic schedule, and probably in the next few years we will be able to establish, ACE will be able to establish itself as a authority of accreditation in embryology in India. Hopefully the whole world looks up to us, and we provide accreditation to these embryologists, and probably they can proudly go and show this to everybody around the world. So thank you so much. Thanks to Manisha, thanks to Aarti, who's been all behind the back grunters, all back people, and also the whole managing committee members who all contributed to this. And looking forward to more sessions like this, and looking forward to the start of the accreditation program as soon as possible, once it's updated onto our website. Thank you so much.
Thank you, everybody. Bye-bye.
With this, we'll close today's session. Thanks a lot, everyone, to our audience, to our team. Bye-bye. Have a very pleasant evening.
Thank you. Bye.